This is Cardiovascular Function and Perfusion. Okay, so if we start with the superior vena cava and the inferior vena cava, they both go into the right atrium, and they go through the tricuspid valve and into the right ventricle. From there, they go up into the pulmonary valve, and then into the lungs, both sides. And then they pick up oxygen at the alveoli, and so now they're oxygenated, and they come back into the left atrium. This is the left side of the heart, and they go through the bicuspid valve into the left ventricle. Then they go through the aortic valve into the aorta, and then into systemic circulation. And then they go through arteries, arterioles, and then capillary exchange, which is the exchange of the oxygen and the CO2. And then it comes back through venules, then veins, and then back up to the superior and inferior vena cava. Okay? Okay, cardiovascular function and perfusion. The blood flow. We just went through it. Superior and inferior vena cava returns depleted of O2 into the right atrium, tricuspid valve, right ventricle. Did I do that right? Yes. Pulmonic valve, pulmonary artery, lungs, O2 and CO2 exchange at alveoli. Then the pulmonary vein into the left atrium, bicuspid valve, which is the mitral valve, left ventricle, aortic valve, aorta into the systemic circulation, arteries, arterioles, capillaries, O2 exchange, then venules, veins, and then back up to the superior and inferior vena cava. The heart lies in the mediastinum and extends down towards the left. The point of maximal impulse is in the fifth intercostal space, which is below rib number 5 on the midclavicular line. The 3 layers of the heart tissue are endocardium, which is within the lining of the heart and the heart valves, myocardium, the myo is the muscle for pumping, epicardium, which means upon, which is the outer, the serous layer to protect the heart. The pericardium is a sac surrounding the heart for protection. It has 2 layers, the visceral on the heart surface and the parietal, the lining. The atria of the heart receive blood returning from the body into the right atrium, and the lungs, the left atrium. The septum, which is Latin for wall and fence, divides the midline of the heart and should not have holes. The ventricles pump blood away from the heart to the lungs with the right ventricle and the rest of the body with the left ventricle. The arterial system transports high-pressure blood from the heart, arteries, arterioles, capillaries. The capillaries permit gas exchange at the end of the O2 line, and then CO2 is carried back up with blood in the venous system, capillaries, venules, veins. The layers of the vascular tubing. Tunica adventitia, the outer layer. Tunica media, the middle, very thick muscle. Tunica intimae, the innermost layer, central part of the vascular tubing. The left and right coronary arteries extend from the aorta and cover the heart. This is where heart attacks happen. The sinoatrial node is the pacemaker of the heart. Normal is 60 to 100, heart rate, rhythm, and regular, sinus rhythm. The electrical signal it travels along the intranodal pathways. Number 1 is the sinoatrial node, intranodal pathways, the AV node, bundle of His, bundle branches, and then Purkinje fibers. Each electrical spark or cardiac cycle. That's one whole cycle. You can see what it looks like, and it's measured in amps. If the T waves are peaked or depressed, it can indicate electrolyte issues with potassium. So peaked is high potassium, depressed is low potassium. Systole is contraction, diastole is dilation. cardiac output is figured out with heart rate times the stroke volume. It'll be in mils or liters for the answer. Heart sounds, lub-dub. The lub is S1, atrial valves, and then the dub is the S2, semilunar valves. The sound is the closure of the valves. S3 and S4 are not normal. They indicate the valves are not closing correctly, and it could be stenosis. The murmurs indicate turbulent blood flow. Pericardial friction rub, heard at the left sternal border and inhibits blood flow. It squeezes the heart. It's a cardiac tamponade. The EKG, electrocardiogram, records the electrical signal going from SA node, intranodal pathways, AV node, bundle of His, bundle branches, and Purkinje fibers. It's one cardiac cycle. One tiny box on the ECG is 0.04 seconds. 5 tiny boxes is one large box, and that is 0.2 seconds. 5 large boxes is 1 second. Goes from left to right. The P wave is depolarization. The T is repolarization, rest and reset. The QRS shouldn't be wider than half a large box, which is 0.2 seconds, so the QRS should be about 0.1 seconds. It should be high and tight. A wide QRS could be a bundle branch block. A PVC can start to look like VTAC if they have more and more. Causes are hypertension, stress, anxiety, caffeine, and smoking, so stop all these things if you can. T wave changes indicate electrolyte issues, as we saw, potassium. Normal sinus rhythm. This is normal sinus rhythm. 60 to 100 beats per minute. Sinus Brady is normal rhythm but slow. It is less than 100 beats per minute. This is Sinus Brady. Well-trained athletes are Brady and it's normal. The LOL meds will lower the heart rate. The patient will have fatigue, short of breath, and dizziness. They are a fall risk. Get a focused heart assessment. Encourage lifestyle changes to the patient to prevent falls. The patient may need a transcutaneous pacemaker. Treatment to increase heart rate is IV atropine sulfate. Okay, sinus tachy. Normal rhythm, but it is more than 100 beats per minute. It's very fast. It can be from overactive thyroid. Signs and symptoms are palpating, elevated temperature, dizziness, lightheadedness, chest pain, and dyspnea. You should try stress management and discontinue things that are increasing the heart rate, such as caffeine and drugs. If the patient is symptomatic, stop them, sit them down, change position slowly, slow the heart rate down. Adenosine, a rapid IV push and flush, will drastically reduce the heart rate. PVCs, premature ventricular contractions. That's what it looks like. The ventricles are overstimulated. Bigeminy is bi 2 every second beat. Trigeminy, tri is 3 every third beat. So the patient may be unaware of PVCs. This is what the bi and tri looks like. Beta blockers, the LOLs, antiarrhythmic meds, the ONs, they may need a catheter ablation to clear out the vessels. PAC, premature atrial contractions. The patient may not have any manifestations, but a fluttering in the chest. The PR interval may be short. The rhythm is usually normal except for the occasional premature atrial contraction. They should try lifestyle modifications and contact healthcare provider if their short of breath begins to interfere with their daily activities. First degree heart block. The PR interval is too long. The first degree of the PQRST has a block. They are on full precautions, and this can happen due to high sodium, cholesterol, and triglycerides. They can modify their diet, encourage exercise, avoid smoking and alcohol. The treatment are meds like lidocaine, metoprolol, diltiazem, amiodarone, digoxin, and magnesium. Atrial fibrillation, it's AFib. Irregular. That's what it looks like. The atria is messed up. The P wave, the atria are just jiggling. They never give a full contraction. It can be from hypertension, heart failure, diabetes, mellitus, obesity, COPD, stroke, thyroid disease, as in hypothyroidism, and kidney disease. It can also happen during post-op recovery from heart cath, and it can happen with diabetes mellitus number 2 if high risk, if it's uncontrolled, and with uncontrolled hypothyroidism, which is low TSH, high T3, T4, they are a high stroke risk because the atria jiggle, they don't move the blood, and the blood coagulates. So more on AFib. St. John's wort, given for depression and menopause, can decrease the effect of anticoagulants, meaning increased risk of clotting. They may need an electrocardioversion. Modify diet to eliminate high vitamin K, which is greens, kale, and spinach. Atrial flutter. Fluttering like the wings of a bird. That's what an atrial flutter looks like. Sawtooth pattern. A recent myocardial infarction or post-op cardiac surgery can cause it. Also, antiarrhythmic meds like LOLs, amiodarone, digoxin. Watch the heart rate if you're giving meds. They'll be lightheaded, have palpitations, hypotension, dizzy, chest discomfort, and short of breath. For both AFib, the jiggling, and a flutter, sawtooth, the nursing role is the same. Blood pressure, pulse, is there a deficit? Interpret ECG, analyze manifestations and potential for clot, improve cardiac perfusion, monitor vitals, and give meds as needed. Encourage patient to discontinue stimulants, smoking, and alcohol. Supraventricular tachycardia. Regular rhythm, but super fast jellyfish. Heart rate is higher than 180. Dizzy, syncope and collapse, hypotension, short of breath, palpitations. They are a fall risk. Try vagal maneuvers, IV adenosine, push and flush. Have defib on hand if using adenosine. And IV diltiazem, esmolol, metoprolol. Okay, the H's of advanced cardiac life support. Hypovolemia. You will see a rapid heart rate, narrow QRS, blood loss. You need to obtain IO, intraosseous, and IV access, either one. Administer fluid or blood. Use the fluid challenge. Hypoxia or hypoxemia. You'll see bradycardia, cyanosis. You need to make sure they have an open airway, ventilate them, make sure their O2 is adequate. Acidosis, hydrogen ion excess. Low amp QRS complex, that's what you'll see. And treatment is get ABGs, provide adequate ventilation, and if metabolic acidosis, give them bicarb, HCO3. Hypo or hyperkalemia. With hypo, you'll see flattened T waves and a U wave. Hyper, you'll see peak T waves and a wide QRS complex. Ventilate if respiratory, and HCO3 if metabolic. Hypothermia. You'll see shivering, and the patient will have a previous exposure to a cold temp. Warm them up. Their temperature should be above 30 degrees Celsius. The T's of advanced cardiac life support. Cardiac tamponade. You'll see a rapid heart rate with a narrow QRS complex, jugular vein distension, no pulse, and a muffled heart sound. The treatment is pericardiocentesis or thoracotomy. Toxins. You'll see a prolonged QT interval. The treatment is based on the overdose agent. Give them supportive care. Tension pneumothorax. You'll see a slow heart rate, narrow QRS complex, unequal breathing, jugular vein distension, and tracheal deviation. They will need a needle decompression or an insert a chest tube. Pulmonary thrombosis. You'll see rapid heart rate, narrow QRS complex. They'll be short of breath, decreased oxygen, chest pain. They need an embolectomy or fibrinolytic therapy or anticoagulant therapy. And coronary thrombosis, abnormal ECG is what you'll see. The treatment is angioplasty, stent placement, or coronary bypass surgery. That's all for that one. And so here is the heart again. Goes through the superior vena cava and the inferior vena cava into the right atrium, through the tricuspid valve, into the right ventricle, and then through the pulmonic valve into the pulmonary artery, which goes to the lungs, picks up oxygen, comes back into the pulmonary veins, and goes into, from both sides of the lungs, into the left atrium, through the mitral valve, which is also the bicuspid valve, into the left ventricle, up through the aortic valve, into the aorta, spouts off there, goes down into systemic circulation, and then all the way down and back up into the inferior and the superior vena cava. This was taken from my notes from the cardiology class. It is not intended as medical advice in any way, shape, or form. This is for my study only. Thank you.